Hello and welcome to Radiance Revealed, the podcast. I'm your host, Dr. Jen Haley. I'm a board-certified dermatologist, fitness enthusiast, nutrition expert, and global explorer that over the years has uncovered that your skin is a true representation of your internal health. Each week, we will chat with leading health, wellness, and even spiritual experts who will reveal secrets to true health and vitality. My goal is to help you change small habits to give you the power to create a more balanced, aligned, and elevated version of yourself. Now let's dive in. Hi, everyone. Welcome back to this week's episode of the Radiance Revealed podcast. And I'm your host, Dr. Jen Haley, board-certified dermatologist. And I am doing an impromptu podcast on skin cancer this week. I just recorded a podcast episode with a fellow board-certified dermatologist, Dr. Noreen Galaria. She has a wonderful supplement line called Inner Glow Vitamins for the skin, for the hair, for photoprotection, and I urge you to check it out. And as we were talking, something came up in my mind that reminded me how uncommon it is for most people to be able to have access to quality information from a board-certified dermatologist. So often, it might take 2 or 3 months to get into the office to see a board-certified dermatologist. And then when you're in the office, because of the way Western medicine is with insurance, it's often a very short visit. And not everything can be answered and addressed. And that's what I try to do in this podcast. I want to give people power and information or knowledge and information to empower themselves to best take care of their health and from the comfort of their own homes. Not medical advice, like there's a time where you need to see your dermatologist. But as we were talking, it made me realize that skin cancer can be misdiagnosed many, many times, and often by non-dermatologists. So I don't think that most people realize you can be the best doctor in the world in your specialty and not do a single day of dermatology in your entire career. So there's many, many times over my career, over the last 21 years as a dermatologist, that I've had someone come in the office with a very, very obvious melanoma. And I don't even understand how they don't realize that it's a cancer. And when I inquire, how long has it been there? They tell me, oh, my primary care doctor or my nurse practitioner or my physician assistant told me it was fine. And I said, well, when was that? And they said, 10 years ago. And I say, it might have been a sunspot 10 years ago. It might not have been. It might have been an early melanoma then, but now it's obviously changing. So the reason for me having this podcast today is to discuss some of the most common variants of skin cancer and when to know to go to a board-certified dermatologist. Because your primary care doctor is often not educated on cancers, skin cancers. And it doesn't mean they're not a great doctor. They're great at what they do. You can go through your entire medical training. Unless you choose dermatology as an elective, you may never be exposed to dermatology more than one lecture in medical school. So that's just how it is. Sort of like nutrition. We don't get nutrition training in medical school either. So you can't assume your doctor knows all of these things. They either have to seek out the extra training on their own, or it just wasn't part of their training. And for the doctors that are listening, because I know I have a lot of doctors that are listening, just remember that your word is often gold and people hold on to that word. And I do a course where I train non-dermatologists to set up an aesthetic practice. And when I teach that course, I'm going to teach some of what I teach in that course today, because I talk about skin cancers and I talk about normal growths on the skin versus abnormal growths on the skin, because we know the longer we're alive, we grow all sorts of things on our skin. There's over 3,000 diagnoses in dermatology. So when should you be afraid and when should you not be afraid? basically, let's talk about basal cell cancer first. So, basal cell cancer, 1 in 3 Caucasians in the United States will get a basal cell cancer. Basal cell cancer is the most common skin cancer. And it doesn't get a lot of press because it often doesn't lead to an increased mortality. So that means it doesn't usually kill you, but it could still be very, very disfiguring. And the way it commonly presents, I can know before I walk in a room. I'll see the paper, it'll say 50-year-old male, pimple on nose, that won't go away. So basal cell cancer often presents as a pimple that won't go away. It just looks like a really slow growing bump, a bump that can take 2 to 3 years to even grow to the size of a half of a pencil eraser. But it looks a little bit different than a pimple. So a pimple normally will go away within a month, right? And you normally don't just get one pimple, you get multiple pimples. But a basal cell cancer, it has a little bit of a pearly texture to it, almost like it's translucent. It doesn't look solid in the skin. And there's usually some little blood vessels growing through it because it's feeding the growth. And I'll often hear a history of it bleeds and then it stops. And most of us are in denial, right? So we say, oh, it's getting better. It's almost going away. Well, in fact, no, it bleeds because it's growing rapidly and then it stops growing rapidly and it holds still and the bleeding goes away, but it's still there. As long as it hasn't 100% gone away, you need to get it checked, okay? So, basal cell cancer often presents as a pimple that doesn't go away. There are other types of basal cell cancers that could look like a patch of eczema, like a red scaly rash, and that doesn't go away either. It slowly grows over time. And there's a type that can look like a scar with no history of scarring beforehand. So that's basal cell cancer. And basal cell cancer tends to happen in areas that are chronically exposed to the sun in fair skinned individuals. So someone who has, I'd say, Hispanic or Asian or lighter skin tend to get basal cell cancers on the face, the neck, the chest and back if they've seen a lot of sun. I don't see it as commonly on the hands like I do with another type of skin cancer, but you can get it on the arms and the legs as well. And I had one patient once in residency, and she kept getting basal cell cancers in the strangest places, and I couldn't figure it out. And I said, I've never seen basal cell cancer on the buttocks before. And come to disclose, she grew up as a nudist. As a child, she had been running around naked all the time, and that sun exposure hit as a child showed up many, many years later as basal cell cancers. Um, Also, there was a generation of individuals who were treated with radiation for acne and for fungal infections, and they ended up developing a lot of basal cell cancers all on their torso and on the areas that were hit with radiation many years later. So, that's basal cell cancer. Very common, doesn't tend to cause anyone to die. It doesn't tend to metastasize. It can in rare occasions, but it can be very disfiguring. And often what we're seeing on the top of the skin, the little pimple that's sticking out, is the tip of the iceberg. So there's often a thicker portion under the skin and a wider portion under the skin. So it can often be shocking when people see how much skin we have to actually remove to clear the basal cell cancer. So just remember, early treatment, early diagnosis, early treatment is the best way to cure anything. The second most common type of skin cancer is squamous cell cancer. So squamous cell cancer is just derived from a different cell type. So basal cell cancer comes from a basal cell at the base of the epidermis, and squamous cell cancer comes from a keratinocyte also in the epidermis. So they have these names based off of what cell type overgrows. And that's basically the definition of cancer. It's one cell type growing much faster than the rest of the cell types, taking up space, taking up real estate so that the cells that are healthy can no longer function. And that's what causes a cancer. And we're actually producing little cancers all day while we're sitting here. But if our immune system is healthy, it has the ability to correct those DNA mutations. So squamous cell cancer, about 1 in 20 people will get a squamous cell cancer. And squamous cell cancer can typically present in the same areas as basal cell: face, neck, chest. I see it a lot on the hands and the forearms, and it looks like a wart. It looks like a big, giant wart. But instead of just sticking up above the skin, it's also underneath the skin with something that I could feel, I could palpate as induration. So when I'm examining a patient, half of my exam is visual and the other half is actually tactile. A lot of my examination is tactile. Is something epidermal or on the top of the surface of the skin, or is there induration? Is there depth? Is there infiltration going on below the surface of the skin? And I can feel that. I can feel that with my fingers when I'm examining someone. So, squamous cell cancer looks very warty, but there's an induration. There's usually a growth under the skin where you can feel a depth to it. And it can sometimes be painful, but I don't go by symptoms. You can have some very bad skin cancers that have no symptoms. So symptoms are not helpful really with these things. If there is pain with squamous cell cancer, I'm concerned about nerve involvement. And these things like to travel down nerves. So that often will make me more concerned. But either way, it needs to come off. So squamous cell cancer can look warty. Now, a lot of people listening may have experienced precancers called actinic keratoses. And these are just scaly little growths. It's basically those squamous cells piling up, piling up, piling up, but they haven't infiltrated down yet deep into the dermis, which is when they become a cancer. And that's why the examination, palpation, and feeling for induration is so key in determining the difference between a precancer and a cancer. So, squamous cell cancer is very correlated to poor immune system function. Over the years, I have had many patients, ranchers when I worked in Western Colorado, people in Hawaii and California who have seen a lot of sun exposure to their arms, to their body, and they develop hundreds and hundreds of precancers. And I see them every 3 months. We take care of as many precancers as we can, and we monitor for squamous cell cancer. And a couple of times, these patients with a lot of sun damage, a lot of precancers, develop squamous cell cancer again and again and again every few months. So in my mind, I know that these are immune related, and every day we produce little precancers, little cancers, and our immune system corrects those mutations and brings the skin back to homeostasis in a healthy place. And when someone starts developing squamous cell cancer after squamous cell cancer after squamous cell cancer, very frequently, when they have a history of not doing so, it's time to take a look inside their body. What else is going on inside the body that they cannot correct these DNA mutations any longer? So I'll usually take a look. Colonoscopy, I've seen colon cancer. Blood counts, I've seen leukemia, lymphoma, I've seen kidney failure. So if the body's busy taking care of some other disease process, it does not have the extra ability to keep the immune system from producing skin cancers. So we know that the skin is a window to internal health, and this is a great example of that. Okay, the third most common type of skin cancer, which is why I became a dermatologist, I wanted to be a pediatrician. So I love kids. Well, first I wanted to be a veterinarian, then I wanted to be a pediatrician. And one day when I was on my pediatric rotation, I was forced to spend a half day in the specialty clinic. And there were a couple choices, and dermatology was one of them. And I said, fine, I'll just do dermatology. It's not like a real doctor anyway. It will be an easy day. So I spent 2 or 3 hours on a Friday afternoon in the dermatology clinic, and my mouth dropped because not only could I have immediate gratification of removing somebody's mole, or it was the beginning of the laser era where we were lasering things and the technology was growing so rapidly, but I could also see older people, younger people, men, women, all parts of the body. It was a very encompassing kind of specialty. And I also realized, wow, I can look at the skin and see what's going on inside the body. I can tell when somebody has a disease inside their body if they have diabetes based off of these knuckle pads. I can see that somebody has a cardiac condition based off of these palm lesions. I can look at their nails and see that they have kidney failure. And I don't have to do all these investigations and poke and hurt anyone. I can look at the skin and tell what's going on inside the body. It's the ultimate Sherlock Holmes. And now we've moved into this era of skincare and cosmetics and lotions and potions, and it's gotten a little fluffy. But, like, honestly, dermatology is insanely academic. We have over 3,000 diagnoses, and when you understand morphology and patterns and even the hues of certain colors of conditions and why syphilis will look different than a viral rash, which will look different from a fungal rash, there's such an art to it that is quite beautiful. It's really quite beautiful to be able to look at someone's skin and know what's going on inside of their body. It's magnificent. So, with that being said, though, I do want to bring to a point of social media nowadays. When people are advertising products, they're getting paid a lot of money for it. I don't do that on my social media. The only things I recommend on my social media are things that I use, and I don't get paid like five, six, $20,000 for it. So it's frustrating for me to see a lot of people they're selling themselves out. They're selling themselves to promote products that they might not even believe in. So be careful who you listen to, check your source, and you could always try something, but at the end of the day, trust what feels right for you. Be a smart consumer. Okay, so anyway, I was doing dermatology and I decided during that pediatric rotation that I thought I wanted to do an elective in dermatology because it was so fascinating. And then I did a rotation through surgical oncology where we remove we remove all sorts of cancers from the body. And most people who are getting cancer, stomach cancer, colon cancer, they're in their 50s, 60s, and whatnot. And I saw all these 20-year-olds. I'm in Southern California. I saw all these beautiful 20-year-olds, blonde 20-year-olds, and I said, "Oh, what kind of cancer are they here for?" And they're like, "Oh, they're going to die." I was like, "What?" And they had melanoma. So this was in the 1990s. We had no treatments for melanoma back then. We were using interferon, but we had no treatments for melanoma. It was find it early, cut it out, and cross your fingers. That was the treatment for melanoma. And I just was very idealistic, as we often are when we're young and we're invigorated to start a career. We want to be perfect and learn everything and save everyone. And I thought, if I can be a dermatologist, I will find all the melanomas and I will save people so they can be saved. And melanoma is the reason I became a dermatologist. And I mean, I've stopped people in yoga. I've stopped people on buses and trains and planes, and I've told them, you need to get that taken off, And I won't do it for basal cell cancer or squamous cell, but I do it for melanoma because it is about finding it early. So let's talk about moles. So there are normal changes of moles throughout our lifetime, and then there's abnormal changes of moles throughout our lifetime. Normal changes of your moles throughout your lifetime is basically to go from Marilyn Monroe, Cindy Crawford, Clint Eastwood. I'll explain. When you're born, you usually don't have any moles, unless you're born with a congenital nevus, a birthmark. But most people don't develop moles until they're 2 to 10 years old. Then they start as brown flat areas or pink flat areas, depending on your skin type. If you have fair skin, your moles will be lighter. They might be pink or light brown. If you have darker skin tones, your moles will be darker or even blue appearing. And that's the first stage of moles. It's brown and flat. As we get older, into our late teens, into our 20s, into our 30s, our moles are like an island coming up from the ocean. They become dome-shaped, and they might still have brown in the center. So you go from Marilyn Monroe, brown and flat, to like a Cindy Crawford mole, where it's dome-shaped and it's brown in the center. And then over more time, as we age more and more, we lose the brown color and it becomes even more elevated and it becomes fleshy and even a little fatty and it loses the brown and it's completely dome shaped like Clint Eastwood. So in all of those cases, the moles are symmetric in color and shape. So even when it's two colors, brown in the center and skin colored on the outside, it's symmetrically colored. The symmetry, you can draw a line through the center and it matches in color and shape on both sides. That's how moles should be throughout your lifetime for most people that have normal, typical moles. Now, some people have atypical moles where all of their moles look funny. And in that case, you really do need to be followed by a board-certified dermatologist, preferably with serial photographs. You check yourself monthly. You see your dermatologist every 3 to 6 months, depending on if you've had a history of melanoma. And in those cases, I look for the ugly duckling sign. So there's something we call the ugly duckling sign in dermatology. Every single person has their own pattern of moles. We all have our own unique pattern. So your moles are different than my moles and different from your spouse's moles. And everyone has their own pattern. So is there a mole on your body that looks different and stands out, not looking like the rest of the moles? And that's what we call the ugly duckling sign. That mole needs to be evaluated. Okay, when do you get worried? If you have asymmetry, if it's changing in color and shape. Now, what if you are someone that has a lot of moles? Should you remove all of your moles? No. Removing all of your moles does not reduce your risk of developing melanoma. About 29% of the time does a melanoma occur in a pre-existing mole. The rest of the time, it's a new spot. Should you remove every new spot? No, because there's so many other normal growths that we get on our body over time. So you really just need to have an awareness of your body. Check your body once a month and look for changes. Have someone take a look at your back once a month and look for changes. So changes, especially in color and shape, should always be concerning. Anything on the body that looks different than something else should be concerning. Now, there are other growths that we grow in our body over time. There's something called cherry angiomas, and they're little collections of blood vessels that we grow over time. They're very genetic. There's nothing you could do to prevent their growth. They could easily be removed in the office as a cosmetic procedure using a laser or an electrocautery device. They are not precancerous. They have the same chance of getting skin cancer as the skin next to it. There's another growth that people don't like. I don't like them when I get them. And pretty much everyone over 30 has them. And they are called seborrheic keratoses. And these seborrheic keratoses, they're very superficial. So my palpation examination is I could feel like I could scrape them off like a barnacle. They almost are like a barnacle that you could scrape them off and you feel like you could just pick them off. And they're very genetic. The number you get is associated with how many your parents had. They tend to run in families. But you will get more if you have high IGF, high insulin-like growth factor. If you have, if you're in a growth state, basically, that means if you're pregnant, if you're gaining weight, you will get more seborrheic keratoses. So there's certain times that people tend to get more than others. There's a rare condition that's debatable called lesser trelade that people develop hundreds of these overnight that's associated with a cancerous growth. I wouldn't think that's happening to you. That's extraordinarily rare. I think I've seen it once over like 25 years. And with the seborrheic keratoses, they can be removed also in the office. I like to freeze them with liquid nitrogen because they're removed very nicely that way. If they're larger, I will remove them using a curette or a shave biopsy. And if they are in someone who has dark skin, in an African American on the face, I call these Morgan Freeman spots. They look like Morgan Freeman spots. Those are seborrheic keratoses, but they have a different name. Even though they look the same under the microscope, they're called dermatosis papulosa nigra, or DPN. And I do not like liquid nitrogen in anyone with skin of color because liquid nitrogen can kill the melanocytes in the skin. So when we're doing something for cosmetic reasons, like removing seborrheic keratosis or DPN, I don't want to leave a scar that's going to look worse than the spot. So be aware that anytime we do something in the office, you will be trading a scar for the spot. It's impossible to remove something without a scar. We could, of course, because of our expertise, make that scar look as small as possible. You need to know in your mind you will always be trading a scar for the spot. So in anyone that has a lot of pigmentation in their skin, I avoid liquid nitrogen because it kills melanocytes, it kills pigment cells. So I prefer to do electrocautery on the DPN on the face. So typically I will take a spot on the periphery of the face and do a test spot where I do electrocautery on maybe 3 or 4 spots. I have the patient come back 2 weeks later. We look in the mirror. How does that look? Are you okay with that? And pretty much most women are okay. Even if it's a little discolored, it's flat and they can put makeup on. And then we plug away and we go towards the center of the face. And I do multiple sessions of this because you always want to ease into things. If you don't like the results, you haven't done all of it. And you do a little bit at a time. Now that will treat whether you're freezing a seborrheic keratosis, doing electrocautery on a DPN, or electrocautery on a cherry angioma. That will take care of what's there today. But as long as you are alive, you will grow more. So let me say that again. A lot of people think that they can get what's there treated and they never have to deal with it again. No, I typically will have to do a touch-up every 6 months to a year because as long as we're alive, we'll keep growing more. So those are not precancerous, whether it's DPN or whether it's seborrheic keratosis or whether it's cherry angiomas. They can have a cancer in them, same risk as the skin next to it. So we just watch it like we watch the rest of the skin. But basically, even when you have those, anytime you have something on your body, and if you're a primary care doctor listening to this, just remember patients trust your word like it's gold. And if you see something on someone, I will say it looks okay today, but we want to keep watching it because our body is constantly evolving and changing. And if something's fine today, it doesn't mean it's not going to be fine in the future. Does it look like anything else on the body? Cherry angiomas tend to come together in clusters. So does seborrheic keratoses. Melanoma doesn't grow in multiples. You just get one. So if something looks different from anything else on the body, if you can't find a twin or a sister or a brother or something that looks similar, get it checked by a board-certified dermatologist. You can find a board-certified dermatologist by going to AAD, that stands for American Academy of Dermatology, aad.org. And you can find someone in your area and get checked. And I recommend people get checked once a year. Unfortunately, insurance does not consider this a preventative wellness examination, but it's a great opportunity to learn about your skin, to get checked once a year, because even the worst thing, if it's found early, is treatable. So it's time for us to take accountability and agency over our own health. And our skin is representing our internal health. So we want to keep it healthy. Okay, so I hope that was some good information for you. And keep sending me your questions. I love your questions. I love interacting with you. And I hope that you can share this with a friend. If you hear someone saying they have a pimple that won't go away, now you know where to send them. Not me, but another dermatologist near you. And share this, subscribe, and please leave a review. I would love that. And talk to you next week, everyone. Bye. If you're enjoying the Radiance Revealed podcast, please don't forget to subscribe so you'll always know when there's a new episode. And while you're at it, please give us a review, as that helps others to find this podcast. And if you want to connect with me, please visit my website, drjenhaley.com, or you can find me on Instagram at drjenhaley.
Hello, everyone. Just a friendly reminder that this podcast is for educational and informational purposes only. The statements and views expressed on this podcast are not medical advice. Opinions of guests are their own, and this podcast does not endorse or accept responsibility made for statements made by guests. Neither this podcast nor any of the information contained within it are a substitute for care by a qualified medical professional. This podcast is provided with the understanding that it does not constitute medical or professional advice or services. If you are looking for help in your journey, please seek out a qualified medical practitioner.